This is the young man, 32 years old, fractured his two upper centrals due to a blow to his upper dentition. He came to our office, and we decided to do this at a live performance in our office January 13th, 2006. First, the check of the colors. The preparation diamonds we are using, slightly tapered, rounded tips, a thinner one and a wider one. The first preparation is removal of the composite. This is the upper right central prepared and the upper left central. Naturally, composite is an option for treatment. So the preparations are going into the embrasures. When we're taking the impressions, we are leaving a matrix on the distal of the centrals to help my lab technician separate the dyes. Here you can see the mock-ups done in the laboratory in order to get a translucent tray to use as the design for the temporary crowns. I spot etch the preparations for better retention of the temporaries. I put phosphate cement above the papillas, not to harm them when the composite comes into the tray, and I cure the composite accordingly. And after this, I remove the phosphate cement and open up the embrasures for better cleaning. So this is just after it's done. The master model with the matrix still in place, the matrix removed, and the laboratory procedure very much summarized here. Cut through the distal to separate the dyes. The master model with the individual dyes, and these dyes are now replaced by dyes in the reflector dye material. Duplication of the master model here, removal of the two central dyes, removal of the central dyes on the centrals, and these are then replaced with the refractory dye material and special pins that will take the furnace temperature without any being affected by that. So we are now producing a master model with the refractory dyes instead of the master dyes. Here it's lifted out. It's marked, the finishing line is marked by special pencil. There's a layer to seal the surface. And now the build-up of the porcelain is done by Claes Marin, my fantastic lab technician. Section by section, and after a few firings, this is the near end result. After this, the refractory dyes are sandblasted, or rather glass bead blasted away. Here you see the actual glass bead blasting away, and now they're tried on the master dyes with a special red color on it, so that it can be trimmed down to a perfect fit. The uncut master model is the model that we try them on to see and check the contact points. The veneers or crowns are etched by the lab technician with ultradense porcelain etch for 2 minutes. Now the patient is back in the chair, coming after 1 week, and here the live performance starts. The temporaries look like this 1 week later. And next to me is my nurse Gunvor sitting with the master dye, so I know where the preparations are. I'm not supposed to cut into the prepared teeth when I'm sectioning the temporaries. I split them open and I wedge them and fracture them. You better tell the patient that it's not you that fracture when you do this, because otherwise they might think that they are the one that are fracturing. It's the composite temporary that's fracturing.
It's not in the tooth.
All those preparations are very thin in the cervical area. As you can see, we have quite some thickness further up into the incisal area. That's because these teeth were standing in a more retruded position, and we wanted them to go a little bit more buccally. In the cervical area, the approximate finishing depth, preparation depth is 0.2 millimeter. I'm just checking that all the temporaries are gone. And after this I spot etch in the middle for better retention of the temporaries. And you've seen that done before, so I just marked that, indicated that now, so I know where my place to remove this bonded composite is. We're trying the veneer, naturally carefully, but we have not fractured many more than 3 during the last 21 years. Checking the fit dry, and then adding water, and the veneer picks up the background color and looks the way it will look with the translucent cement under it afterwards. Checking the fit with water. Quite often we use also the water-soluble trying paste for this. We use the Videoloengu cement later, and we use the Videoloengu trying paste. So here are the 2 veneers tried in from the buckle and from the incisal. They tried in with water here. And the patient will now have a look at it, and the acceptance is total. And so is our acceptance of the veneers. That was a little nod you just saw there when he accepted the veneers. He's not very dramatic in his speech. Now it's time to clean the teeth, and we can clean these by pumice of water. We can also clean them by sandblasting, which we do quite frequently, quite often. Now when we do the sandblasting, we will first put the rubber dam on, so we don't hurt the gingiva more than necessary. So this is pumice and just water to clean them. You can watch the invagination in the cervical area, which naturally makes the rubber dam placement a little bit more critical, because the anatomy of the tooth buccally is not normal. It has the invagination in the central part of the buccal surface. So Gunvor puts the rubber dam on. We're opening up the lateral, because the contact point with the central and lateral, it's important that that is open during the seating of the veneer. The number 211 clamp, we'll use a frame to stretch the rubber dam. And now the tooth, the prepared tooth, is clearly visible. The mesiobuccal preparation is open there, but the distal buccal is a little bit covered by the rubber dam. So then I will use the UltraPack retraction cord to drag the rubber dam into the embrasure. This is especially useful when you have a retainer after orthodontic treatment, for instance. So here's the UltraPack retraction cord. Put it there dry and push it in with a carver. This will then move the rubber dam past the finishing line of the preparation into the embrasure. And now we have full access to the prepared tooth. On the palatal, there might be a little bit gap there. You can see the gingiva coming up there. And then we are using the block-out resin. Block-out resin is ultra-dense, light-cured blue resin that sticks pretty well to the tooth, to the clamp, and to the rubber dam, which means that when I now cure it, it will seal off the palatal part. Perhaps not necessary here, but we did it anyway. This is especially useful when we're sealing for bleaching teeth, because then it's very important that the bleaching material does not harm the gingiva. But here we do it to seal it from moisture. It's cured for about 20 seconds. So we try the veneer, and it looks like if it's touching the clamp, but it is not. You will see that later when we try the other centralion. It is not, but it's very important naturally that it does not interfere, or that the clamp does not interfere with the seating of the veneer.
Put away your fingers.
You say no?
Klaus doesn't want me to do this too much. Pardon? It's okay. Not right now.
The inside of the veneer has been etched by hydrofluoric acid by the lab technician, and it's now silanized to get a little bit increase in the bond, and you will thus get a little bit of chemical bond between the composite cement
Okay?
and the veneer.
No, not too many objects.
Most of the retention naturally, the strength in the bond will be from the fact that we have etched the inside with hydrofluoric acid.
Since this came with the material on the market, so we're continuing doing it.
Sorry, which do you not think is necessary? The silane?
I'm protecting the lateral's mesial surface from being etched by just putting a matrix, a metal matrix,
Right.
to protect it. I can now etch the central,
This matrix here,
and I'm preventing the enamel to be etched on the lateral.
central, I don't want to etch the
Because if it was etched, I might get a 2-unit bridge
many people
after the cement
other people
touches the mesial surface of the lateral.
procedure. We're not doing that. Because then you have to wedge as well. And you cannot always wedge. You never know if you have a dent in the line.
We use the
I will just
Ultradent Ultra Etch 35% phosphoric acid in a gel form, and we will etch the enamel and dentin for 15 to 20 seconds.
That's the primary.
After that we will flush water for 20 seconds, the least, to remove the etching.
For 1 minute
It's very important naturally that all parts are being etched.
in the porcelain also.
So for 20 seconds at least I will flush away the phosphoric acid. The porcelain primer is being used on the porcelain, silanized, and then we have the A plus B, the Bisco's A plus B, all bond 2, applied 5 to 6 times. This is now the dentin bonding agent. We're using this even if there's only a little bit dentin exposed, because you never know where the dentin is exposed. Here we know that it's the incisal part. So this is the all bond 2, A plus
we
B,
don't cure it normally.
mixed, applied 5 to 6 times.
Discuss that later, but now we're bonding it.
After this comes the resin, and in this case, with light cured cement, we are using the dentin enamel resin, the left bottle. We're using a green handle on this brush. Green means go, as you know. We are now injecting the Videolink 2 cement. This is just translucent, light cured cement only. We inject it because you get less porosities by doing that. We are using the green, as you see. Earlier we use it because it's green and we go, and now we use the green one to remove the excess cement.
But surely go up approximately. Very good. That works.
And then we cure it for 100 seconds, about between 100 and 120 seconds.
On the cervical area and the mesial surface.
We do not make a spot curing here and then remove more of the excess cement. We will put the veneer in place, remove as much cement as we can, and then cure the entire length of the period for about 100 seconds. First one is there, and you can see the Ultra Pack retraction cord coming out of the distal buckle. Has to be removed naturally. And we're using a variety of instruments. Many years ago, 10, 12 years ago, we used a lot of polishing. But polishing means that you're you're harming the porcelain very often. So we're using mainly hand instruments now, and you can see quite a few of them here. Scalpels is also one instrument that we are using most of the time. The blue on the palatal there naturally is the blockout resin still there. On the palatal sometimes we are using a 48 a steel carbide burr with 48. Yes, with 48. Well, with 48 on them. And then we're using some dental floss, and here we're using just a matrix to go up and remove some of the composite cement. This is just a rough cleaning of this now, because we have to see that there's no composite interfering with the seating of the second veneer. So naturally it's very important that there's no cement on the mesial of this upper left central that will interfere. Now we are using a scalpel. First one in place, second one to go. Watch the dry out effect in the laterals incisal part as compared to the most cervical. The drying out effect is because that part has been dried out because of the rubber dam placement. The cervical part has been wet because that was above the rubber dam. You have to inform the patient about this, because the teeth adjacent to the one we are bonding will bleach temporarily. That means that if they matched in color before, the adjacent teeth will now be brighter in color. After a few hours, or maximum 24 hours, they will be back in their normal color. But the patient has to be informed about this beforehand. We try the second veneer in, and if you feel that it's a little bit too tight, as we feel here, we take a thin articulating paper. I will hold the veneer in place, and Gunvor, my nurse, will take a plier and try to drag this out. And you can see when that it's stuck there now. I have to tear it if you're going to get it out, and that means that the contact point might be a little bit too tight. Now we can leave it like that, or we can wedge the teeth apart. Depends on the situation a little bit. But in this case we will try it once more to see if it's still a little bit too tight. And if it is, I will just use a silicone rubber wheel to polish away, and you can see that it is a little bit too tight. There should be a contact, but the contact point should not be too tight. So the marks, you can see them on the mesial of the central, and I will just polish this away with the silicone rubber wheel. Be careful now so you don't get into your gloves there, because then you flip, it will go away, and we have to start all over again with a new veneer. Now we're trying it in with the rubber dam on. You can see we haven't sealed it on the buckle yet. We'll do that later. We're trying now to see that the clamp is not interfering with the seating of the veneer.
To see it, it has to be dry enough.
You will now see the invagination. It looks like it's all the way up here, but we'll just take a photograph of this in a second, and we'll show it from a more buccal point of view. Click. That was a picture taken, and this is a picture just before total seating. As you can see, there's still this is a second click, and now it's all the way up, dry, and that's why you can see the finishing line clearly.
No, I haven't squeezed it. No, it's because
so we don't always take this picture, but that's just for you.
Okay.
We seal off the leaking area with the UltraPack retraction cord again, the blue one. We use it dry and push it up there, which means that we are sealing the area now. And as you can see, we have both contacts open now, because both contacts are now important. Because if the rubber dam came down between the lateral and the central here, for instance, I would not be able to seat the veneer. Or if the rubber dam came down between the centrals, the rubber dam would prevent me from seating the veneer. So open up the contact points that are important for seating one veneer. So now we etch, we are protecting the lateral, but we do not have to protect the central, because that's not enamel there. That's porcelain, and porcelain is not affected by the phosphate cement. Porcelain can only be etched by the hydrofluoric acid. So you can note the protection of lateral from being etched. It's rinsed away, and now it's the A plus B, the viscose all bond 2 applied to enamel and dentin. 5 to 6 consecutive coats. You dry it with water-free air, and it's time for the resin, the dentin enamel resin, and the green brush. I know then that the cement is coming next. Blow the resin out a little bit, and here comes the cement in the syringe, and we are syringing it because we get less porosities in the veneer. Why don't we put it on the inside of the crown or the veneer? Well, we sometimes do, but the veneer gets so slippery so that when you do it, you might have a risk of, dropping it. It might slip away from your hands. I'm holding it, and Gunvor, my nurse, is removing more excess cement. And then here comes the lamp. Curing lamp for about 100 seconds.
It goes out and it sucks up.
Now removal of the clamp and the rubber dam. Now again, watch the drying out effect of the laterals. Whenever you see them, you can find that the inside part of the laterals are brighter in color than the cervical. Now you can't see anything at all. So as I said earlier, we're using quite a few instruments, and scalpels are one of the best. We're checking naturally the occlusion. In his case, he had a crowded type of position of his teeth in the lower arch, so the incising will never be perfect. He should need orthodontics actually. But this was a trauma case coming almost from the street into our office.
Difficult to go back with teeth. The crowding and the fact that
Yeah, here you have the lower crowded dentition. We polish very little, as I said, but the palatal finishing line we most often then polish with a silicone rubber wheel, and we finish it off with a bristle brush, as you will see later. The other areas are just polished, or the composite cement removed by hand instruments. This is the bristle brush for final polishing. And we will always bring the patient back a week later to see the final outcome. And very often, if you have excess cement at that time, we will clearly see that, because the gingiva will not then be healthy. This is directly after bonding. Everything looks terrible, and please inform the patient about this before, that they will be bleeding, the gingiva will be irritated. But in a few days, it will be perfect. This is right after, with the bleeding gingiva. Right after. And here's a look. And, yeah. Oh, that's me, the operator. Naturally, we should have class there as well. And go on. So, walk on by. Everybody walks on by to see what it looks like afterwards. These are the 40 people taking our course January 2006. This is 40 people taking our course January 13th to 14th, 2006. Här är Erik Svensson, ja, Ulrika Funevård.
Just walk by because it's
Just walk on by, way on the corner. I love you, but we're strangers when we meet. Just walk on by,
Just walk on by.
wait on the corner.
And have a walk.
I love you, but we're strangers when we meet.
by the camera and glass and me. Yes, it's good.
Naturally, when you're filming things like this, the angle of vision is not really the right one. The problem is that I have to see as well when we treat the patient. So, therefore, by showing you the pictures after a week, taken by photographs, you have a better possibility to judge the end result. And we were all very happy, especially the patient as well.
Jag får blåsa torrt dem sen. När det är våta så ser du inte att de verkligen går upp där. Du tar det i kameran sen. Because they look a little bit grey.
As I said in the beginning, composite is always an option in these cases.
See that they are not grey.
We know now, after 21 years of veneer making, that these will be there 21 years later. That is also the reason why we will bring in the finishing lines to the palatal surface, because the discoloration that will come in the finishing lines, due to the changing color of the teeth, not the least, will then be on the palatal and will not be visible. So therefore we are now perhaps a little bit more invasive than we were earlier. We are bringing many of the finishing lines as the mesial finishing lines on these two teeth into the proximal. These teeth, we did not bring the distal finishing lines into the palatal surface. And our main goal is to, here he is now, 1 week later, 2 weeks later. As you see, the gingiva has now healed completely. The only thing you can clean with toothbrushing and floss. Nothing else.